Good evening, and thank you for joining us for another International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants. Tonight, the title of our program is An Invitation, 5 Years in the Making. As moderator this evening, we have Dr. Leon Kircik, President, International Dermatology Education Foundation, Clinical Professor of Dermatology, Icahn School of Medicine at Mount Sinai, New York, Indiana University Medical Center in Indianapolis, and Medical Director of Physician Skincare, DermResearch, and Skin Sciences in Louisville, Kentucky. As our speaker this evening, we have Dr. Michael Payette, founding partner of Central Connecticut Dermatology and Associate Clinical Professor at Icahn Health. We would like to thank our supporter this evening, Sun Pharma, for making this educational event possible. A couple of logistic tips before we begin. If you are having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill in this short survey. Also, within 1 to 2 days of the webinar, you will receive a certificate of attendance. And we will have a Q&A at the end of the program, so please submit your questions using the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Kircik.
Thank you, Ashley, and good evening, everyone, and thank you for joining us for another episode of International Dermatology Education Foundation educational series. I just want to tell you a little bit about the IDEF, International Dermatology Education Foundation, before we start our program tonight. IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And since pandemic, we've been doing our virtual programs all over the world, including not only in North America and Canada, but also in Latin America, in Southeast Asia, and in Europe. As you can see here, a couple of our previous educational programs that we have done in the past. However, tonight, we are very lucky to have a special guest, but also please stay on with us at LinkedIn, Facebook, as well as Instagram. So tonight, our special guest is Dr. Michael Payette, who is a founding partner at Central Connecticut Dermatology. He's an associate clinical professor of dermatology at Icahn Health. Welcome, Michael. But before we start our program, I really want an explanation from you. What happened to your beard? So I know ILUMYA is important, but I think people are going to wonder what happened to your beard.
Thanks, Leon, and really thank you for the opportunity to be here this evening. It's a great question and arguably could be the most important one that I'll get tonight. So for those of you who don't know me, I'm a diehard New England Patriots fan, and there are 2 times during the season where I shave my beard, September 1st, and then whenever my team is knocked out of the season, be it the regular season or the playoffs. So regretfully, on September 1st this year, I had to shave it again. It's a tradition that I've done for probably about 20 years now, and every time I do it, my kids insist that I'm not their father for a short period of time. But the good news is, in 2 weeks it'll be back. So, but again, thank you for the opportunity to be here. It's a really special privilege. I've been good friends with Leon for a long time now, and I'm really, honored that he asked me to give this presentation to you guys tonight. So our talk this evening is on ILUMYA, or tildrakizumab, a lasting treatment for the patients you see every day, an IL-23 inhibitor for moderate severe plaque psoriasis. Obviously, I just have to go over a few housekeeping items. This is the promotional program that was developed by Sun Pharma. I'm not an employee of Sun Pharma, but I'm certainly representing the company on their behalf during this discussion. All the information I'm going to be presenting this evening will be consistent with the FDA applicable guidelines for this medication. Nobody, myself included, is getting CME credit for this. I do receive compensation for giving this presentation tonight, and pursuant to open payments and other similar state laws, all transfers of value will be reported, and copies of the full prescribing information for ILUMYA are available at this presentation as well as on the website. I always like to focus on the legacy I think that Sun Pharma has in dermatology. Obviously, we're talking about their biologic this evening, ILUMYA, but they have footprints in many different facets of our field, with Ascorbica LD and Winlevi in acne, with Levulan, Kircik, and Blue Light for actinic keratoses, for Odomzo for skin cancers, basal cell skin cancers in particular. And it's always a big deal to me when a company has many different aspects of involvement in our field, because it says that they're really not only just geared to helping us, but really helping us take good care of our patients. Our learning objectives this evening are relatively straightforward. We're going to characterize the presentation and pathology of psoriasis. Hopefully this will just be a very basic review for all of you. We're going to describe the efficacy and safety of the data surrounding ILUMYA for adults with moderate to severe plaque psoriasis. We're going to review that efficacy, safety, and data in a specific study looking at the phase 3B scalp study. We'll obviously talk about some real-world evidence and highlight the value that this medicine delivers for real-world patients. And we'll describe some support services at the end to help you get this medication for your patients who deserve it. I always think there's three important things with any medication. You have to know who it's indicated for, does it work, and is it safe? So obviously right now for ILUMYA, it has one indication in dermatology. It's for adult patients with moderate to severe plaque psoriasis who are candidates for systemic and phototherapy. I always wonder sometimes why this language always comes up, candidates for systemic therapy and phototherapy. You know, it's interesting because when the FDA initially approved these medications, that was the criteria. So for all new biologic medicines for moderate to severe plaque psoriasis, you're always going to see that last line there, candidates for systemic therapy or phototherapy. One of the things I like about ILUMYA, though, is in terms of safety, it's a very clean, safe drug with very few contraindications. In fact, the only contraindication for this medication is if you have a previous hypersensitivity to the product or any of the excipients in the product. In terms of warnings and precautions, obviously hypersensitivity, as we just discussed. Infections, as is true with all biologic medicines, ILUMYA may increase the risk of infection. When we think about the pathogenesis of psoriasis being a type 1 inflammatory disease, the cytokines that our patients produce in this scenario protect them from getting other infections. And so when we start to muddle with that immune system by picking off different cytokines, we theoretically increase that risk for infection. Obviously, you're going to always consider the risk and benefits before prescribing ILUMYA for any patient who may have a chronic infection. And certainly you would not want to start this medication if a patient has an active infection until that infection is either controlled or resolved. Other warnings and safety, you do have to pre-treat for tuberculosis. This is really a class label. If you think about how granulomas are formed, it's true that all of your cytokines that are part of the type 1 inflammatory pathway play a role: TNF-alpha, interleukin-17, interleukin-23, interleukin-12. But it's really only a TNF-alpha that actually surrounds that granuloma and keeps it locked up. So the risk of latent TB reactivation with IL-23 inhibition is very low. Nonetheless, I think it's very good medicine anyways to always screen your patients for TB. And of course, there may be variations in terms of where you work regionally, where TB may be more endemic than, say, for example, in Connecticut, where I work. Immunizations, same language you see here, is consistent with all our biologics. You want to avoid the use of live vaccines, and you should try to make sure that your patients have all their age-appropriate vaccinations. You know, obviously, with a long-acting agent like ILUMYA administered every 12 weeks, that can sometimes be a challenge. You know, my personal approach, if a patient requires a vaccine, is I administer in the last 4 weeks before their next upcoming injection. And then when we look at adverse reactions, although we don't have comparative studies to other biologics, you'll note right away that this is probably the shortest list of adverse reactions for an IL-23 agent. We see only 3 things listed here: upper respiratory tract infections, injection site reactions, and diarrhea. Now, it's noteworthy that injection site reactions, I think, are always overstated because they include things like pain, bleeding, and bruising, which are not true injection site reactions. A true injection site reaction really should require some type of inflammatory response at the injection site, be it erythematous, eczematous, urticarial, or whatnot. We also know that psoriasis is a worldwide disease and really affects every race, every gender, and every age. In the United States, you know, the rough prevalence is somewhere between 2 and 4%, depending on what study you look at. Here we're showing about 3% of the population has psoriasis. And we also recognize that the clinical manifestations of this disease vary based on a number of different things. Certainly, the appearance of the typical, psoriasiform plaques with micaceous scales, what we think about. But when we move into darker skin colors, we may not see that bright red erythema. It may present as more of violaceous or brown color. In African American patients, the psoriasis tends to be in a background of xerosis, which is different than what we see in our Caucasian patients. So it's always important to understand how the disease presents in different skin types and also at different ages. Now, the other thing that's important about psoriasis, and when I talk to residents and medical students, I always really ask this question of, do you think this is a systemic disease or not? And I think if you're still in the camp or you think this is a skin isolated disease, I think we're missing a lot, right? We all recognize that this is a systemic disease. But in terms of focusing on just the skin component first, we know that it has varied areas where it can have impact. Obviously, some of these areas might be more important than others. For example, scalp psoriasis and nail psoriasis portend a higher lifetime risk for developing psoriatic arthritis compared to psoriasis patients who don't have involvement in these areas. Estimates are about 3.9-fold higher likelihood if you have scalp disease, 2.9 higher likelihood if you have nail disease for developing psoriatic arthritis. I think we forget sometimes that a lot of patients with psoriasis have facial involvement, which can obviously be very bothersome to them. About 20% have involvement in their intertriginous areas. In fact, genital psoriasis is one of the things that I see quite commonly, and I'm actually part of a general psoriasis consortium right now working on elucidating this as a component of psoriasis and helping our patients recognize that this is actually an inflammatory disease. Probably palms and soles are one that we struggle with the most. Obviously, if you have disease on your hands and feet, it can impact not only your quality of life at home, but also your job. But it's just important to think about all these areas. And anytime you see a patient with psoriasis, you really owe it to yourself to do a complete skin exam to identify all the areas of their skin that are involved with this disease. But it goes beneath the skin as well in terms of the systemic components. And I think for me, this is always a rationale is like, why consider a topical medicine when you're talking about a patient who has psoriasis, when we recognize that there is a systemic undertone here. We know in many instances, psoriasis can be associated with cardiovascular disease. And I think we have a lot of emerging research in this area. And I think we'll see in the next 5 to 10 years, hopefully at least, that treatment of psoriasis can help reduce some of these cardiac morbidities. We know that psoriasis at baseline is associated with increased anxiety and depression. In fact, it's not uncommon when we administer therapy to patients with psoriasis, systemic therapy that is, that we see anxiety and depression improve. And of course, probably the big one is the metabolic syndrome. So in the United States, unfortunately, we tend to be a population of being a little overweight. So about 40% of patients in the United States have metabolic syndrome, which is really double that of those without psoriasis. And I find that estimate might be actually a little bit low. Of course, now with our GLP-1 analogs that we have, we might see these numbers change a little bit. And it should also be no surprise that we have, verified research that shows a relationship between systemic inflammation and the underlying immunology mechanisms in psoriasis and cardiovascular disease. In fact, in most instances, I think inflammation is always a problem, not only in psoriasis, but in many of the diseases we treat in dermatology. But with specific numbers focusing on patients with psoriasis, these folks have a 50% increased odds of having cardiovascular disease compared to patients that don't have psoriasis. That's not a small number. There's a higher incidence of major adverse cardiac events, be it myocardial infarction, ischemic heart disease, vascular accidents in patients with psoriasis compared to those without. And of course, the risk of these increases with your increasing severity of your psoriasis. So biologic therapy is now in our lexicon for almost 25 years now for treating patients with psoriasis. And this biologic therapy, may actually reduce or at least modulate the inflammation that then favors or portends a better outcome in terms of cardiovascular disease. So we know, if we look in the center here, that we have a host of cytokines that are involved in our psoriasis pathway. The nice thing is we have targets for all of these. We have a number of TNF-alpha inhibitors. We have 4 IL-17 inhibitors. We have 1 12/23 inhibitor. We have 3 IL-23 inhibitors specifically. We also have some systemic small molecules that we can use now. And all of these medications, when used appropriately, can reduce the systemic inflammation and therefore potentially have a cardioprotective effect. They have the ability to improve lipid-rich atherosclerosis. They also have an association between reduced non-calcified coronary plaque disease. And consequently, we hope to see at least a lower incidence of MACE events as a result of instituting this therapy. Of course, these things take long periods of time to prove a relationship. Now, I don't want to bore anybody with getting too much into the weeds here with the mechanism of disease, but I think it's really important for us as providers to always understand the why behind the drugs that we use in terms of how they work. Our patients may not care as much, but we should always have a good, clear understanding of what's going on. So this is obviously a very simplified schematic here, but we know that we have dendritic cells that exist in our skin. These are the sentinel cells that respond to a whole host of different triggers. Obviously, in psoriasis, it's also a genetic component that can play a role. But in the presence of the appropriate stimuli, these dendritic cells get activated. They secrete interleukin 12 and 23. Interleukin 23 then acts on a naive Th17 cell to drive that Th17 cell to become pathogenic. That Th17 cell then secretes its own cytokines, of course, namely interleukin 17, but also TNF-alpha as well. And these cytokines then result in the clinical characteristics that we see with psoriasis. And of course, you get this typical feedback loop where the inflammation increases further inflammation. We know that IL-23 maintains the dermal Th17 cell and actually is the main regulator for whether that cell becomes pathogenic or non-pathogenic. So biologic treatment, in this case, using a molecule like ILUMYA that basically gobbles up interleukin 23 within the serum, then switches that pathway backwards and drives that Th17 cell from being pathogenic to becoming non-pathogenic. And of course, we get the reduction in cytokine secretion, which then leads to the clinical improvement that we see in our patients with psoriasis. So tildrakizumab specifically targets interleukin 23. You should remember that interleukin 23 has two subunits, the P19 and the P40 subunit. So in this case, ILUMYA is specifically targeting the P19 unit, which is why it only acts on interleukin 23. Whereas ustekinumab or Stelara binds the P40 subunit, and that's why you get IL-12 and 23 blockade with that medication. Okay, so moving on to efficacy and safety. So when we look at the two clinical trials, Resurface 1 and Resurface 2, and I'll be the first person to say that when this was one of the first IL-23s to be studied, and when the data came out, there's a couple things I think that are noteworthy. In fact, I kind of initially poo-pooed this drug in terms of its efficacy, but one of the big drawbacks was when it was designed initially, they used a 12-week endpoint as their analysis. Now, for those of us who work in clinical trials and work with these longer-acting agents, we all know that these medicines enrich over time in many ways like red wine. And you almost never see a 23 study looking at a week 12 endpoint, right? The longer you look, the farther down, the better these medicines look. Medicines that are farther down in the pathway, such as your IL-17 molecules, prefer to look at earlier endpoints. But nonetheless, this was how the trial was designed. So at week 12, we can see in both Resurface 1 and Resurface 2, looking at our PGA responders. So this is your psoriasis global assessment score. It's a 5-point score going from 0 to 4, 0 being clear, 1 almost clear, 2 mild, 3 moderate, 4 being severe. So we're looking at the number of patients who achieved clear, almost clear. And at week 12, we have about 50% in both Resurface 1 and Resurface 2, certainly much greater than we saw with our placebo response rate. As you then follow this analysis out to week 28, you can start to see that enrichment that I talk about with these agents, where now you're over 60%, and in Resurface 2, nearly 2/3 of patients achieving clear, almost clear with ILUMYA. And also remember that this medicine is only, at this point, patients have only received 2 injections at week 0 and week 4 before any other injection. The next injection would be administered at week 16. Okay, in terms of PASI scores, I think PASI scores are an important aspect of any clinical trial. I don't think they translate really well into clinical practice. For example, let's just say you have a PASI score of 20, and that looks at body surface area and also 3 components: how indurated you are, how scaly you are, and how red you are. And those can all be graded from 0 to 4. So a patient may have pretty severe psoriasis in terms of these 3 parameters, and their PASI may be a 90% improvement going from a 20 to a 2, as manifested by less scaliness, less induration, and less erythema, but they may still have the same exact body surface area being impacted. So I think it's important for us to understand it, but I don't think it necessarily translates really well into a conversation with patients. Nonetheless, what we can see here is 2 things I would really like to note. Number 1, we're looking at median scores here, And we note right away that there's a very rapid decline within the first 12 weeks, where patients are, the median point is 83% clearer in terms of, through at that time point. And then as we follow these patients out through 5 years, we see very clear stability of the line hovering just around about 1, which is great. So patients are 94% clearer at week 5, maintaining that 96% clear that they got at the end of year 1. I always think that in dermatology, pictures speak, much more volume than clinical data. So here we have an example of what this might look like in a patient. Here we have an individual with a baseline PASI score of 16. That would be considered pretty significant psoriasis. You can appreciate the broad surface area involved here in terms of the extensors on the elbows, the upper back, the flanks, and presumptively going down onto the around to the abdomen there. At week 12, after just 2 injections, this patient has now achieved a PASI score of 2.3. And I think we'd all agree that this patient would probably be quite satisfied being 86% clearer than they were a mere 3 months prior. At week 28, you see that enrichment that we speak about, where now this patient is down to a PASI score of 0.6. At this point, of course, they've received 3 injections, 0, 4, and then at week 16. I also think that anytime we're looking at PASI, if you want to focus on PASI, if that's an important component for you when you're talking to patients, you want to get that score down under 1 if at all possible. And that's reflected here in that patient at week 28. Okay, switching gears for a moment to safety. The second part of any good drug is it has to be safe. And I think the first thing you'll note right away here is that we don't see a lot of large numbers. In fact, anytime you look at a safety slide, I always encourage you, before you even jump into the numbers, to look at the stuff on the left and ask yourself, is there anything over there that I really should be concerned about in terms of doing harm to my patient? And we'll get into that on the next slide. This is more just kind of your global overall adverse events. So we see treatment emergent adverse events, treatment related adverse events, serious adverse events, treatment related serious adverse events, discontinuation due to adverse events, and discontinuation due to treatment adverse events. So when you have a slide like this, it's important to kind of ask yourself, what actually do I really care about here to help me move through this data? So I actually really care about discontinuation rates. Discontinuation rates to me are a very good surrogate marker for a drug in terms of both efficacy and safety. So if we look at our discontinuation rate due to any treatment emergent adverse event, we can see that in our ILUMYA arm, through week 12, we had 4 patients, 0.6% discontinued, which is the exact same number of patients in the placebo arm. Then, more importantly, when we look at discontinuation rates that are due to a treatment-related adverse event, so this is an event that the investigator has now labeled being attached to the actual medication, we see only 1 patient out of 700 discontinued in those first 12 weeks due to an adverse event, which is arguably 50% lower than we saw with our placebo arm. Our serious adverse events are namely infections. We see very low rates there, 1.4 and 1.7% respectively. When we look at our full trial and extension period on the far right, we're now looking at data that's being presented in eventful 100 patient years. Again, in this type of analysis, you want to see things that fall below 1. The way that I simplify this is assume you're following 100 patients for 1 year. Any number that you see here is the number of occurrences that are going to happen. So if you see something above 1, the assumption would be that at least 1 patient out of 100 is going to have that adverse event. So things below 1 are important, and we see that in the bottom 3 there: treatment-related AEs, discontinuation rates, and discontinuation rate due to treatment-related AEs. Oops. I skipped a slide. Give me 1 second here. Okay, but here we're now we're actually looking at the actual safety. All right. So the first thing we do, again, look at our safety signals on the left. We see confirmed MACE events. We see infections. We see malignancies, including both non-melanoma and melanoma. We see ISRs, drug-related hypersensitivities, oral candidiasis, and candle skin infections. So now there's some stuff that I care about. So in our first 12 weeks, we had 1 confirmed MACE event, 0.1%, which, although I know we don't have head-to-head data with the other 23s, that is anecdotally on paper the lowest that we see with the other 23s through that time period. And when we look out along with the full trial, it's an incidence rate of 0.5. Arguably saying you'd have to treat 500 patients. You have to treat 200 patients to see 1 incidence of a MACE event. Serious infections also low, 0.1%. Malignancies low, 0.3, 0.3. Non-melanoma skin cancer 0. Again, our injection site reactions are overinflated here because, again, I think they include things that aren't true ISRs at 3.4%. And then the rest of these things are all 1s and 0s. So again, a very clean safety profile, in my opinion, for ILUMYA. But this is probably even more appropriate. This is now looking at things that occurred in the trial arm compared to placebo, occurring in more than 1% of patients with placebo. And again, that's where we see only 3 things: upper respiratory tract infections, injection site reactions, and diarrhea. And even our upper respiratory tract infections are only 2 percentage points higher than we saw with placebo. In my mind, that's a wash. Our injection site reactions, 3%, and then our diarrhea, 2%, 1%. So really nothing standing out here in terms of being worrisome. If we look at the circles on the bottom there, you can actually make the case that maybe ILUMYA might be safer than placebo. And I'm certainly not making that case, but when the numbers fall below the placebo arm, that's always very reassuring, right? So we actually had fewer adverse events overall in our ILUMYA arm compared to placebo, 48 and 54% respectively. We had half as many serious AEs, 1% and 2%. Our rates of common infections were on point, 23% versus 22%, and the rates of serious infections were also identical at less than 0.3% for both the ILUMYA and placebo. And then in the purple bar at the bottom there, this is always something that resonates really well with patients, where you don't have to really talk about things like cardiac disease, malignancy, suicidal ideation, inflammatory bowel disease, C-mind disease. Right? So I think for a lot of patients, safety is an important thing. With a medication like ILUMYA, you really only have to address 3 things: injection site reactions, upper respiratory tract infections, and diarrhea. Okay, let's look at scalp psoriasis here. So this was a phase 3b trial, and I think this was an important one to study because scalp disease, in many ways, like palmar-plantar disease, it's not only a separate entity, it's a really bothersome entity for patients with psoriasis. Oftentimes, this is going to be the itches that patients, if they have plaque psoriasis in other areas, this is going to be the itches site of involvement. Obviously, nobody likes to have the fact that they have flaking and scaling, landing on their shoulders. Anytime you see a patient with scalp psoriasis, you're often going to see them scratching their head to deal with that, which then can lead to bleeding. So I think it was good that Sun decided to study this. It's a small trial, but it's a 72-week, multi-center randomized double-blind study, and it really just looked at the efficacy of ILUMYA specific to moderate severe scalp psoriasis. You had to be an adult patient, consistent with the label. Again, you see that candidate for systemic therapy, and no active or untreated latent tuberculosis. Of course, that's a requirement for screening anyways. In terms of our inclusion data with regard to our patients, they had to have moderate disease for at least 6 months. They had to have an IGA of the scalp greater than 3. It's essentially the same thing as a PGA, but now we're just looking at it just specific to the scalp. Same is true of the PSSI, that's your psoriasis scalp severity index. Again, very similar to your PASI. Had to be greater than 12, and you had to have at least 30% of your scalp affected. And again, we're going to be looking at the ability to achieve clear or almost clear in our analysis. Here's the study design. You can see the little injection points there as for every administration, which again is going to be week 0, week 4, and then every 12 weeks thereafter. That's when patients are receiving their injections. Our primary endpoint is ability to achieve a scalp IGA of clear or almost clear. They also had to have at least a 2-grade improvement, which again, from if you're moderate, you're 3, severe, you're 4. So by default, you're going to have that 2-grade improvement by getting to 0 or 1. Our assessment, our secondary endpoints were at week 52, 90% PSSI at weeks 16 and 52, and a scalp itch NRS. Your NRS score is the same that we are all accustomed with. It's a 0 to 10 score, where typically 7 to 10 is considered severe, 4 to 6 would be moderate, 2 to 3 would be mild, and 0 to 1 would be no or minimal itch. And then we'll also look at the DLQI, which hopefully you're all familiar with, the Dermatology Life Quality Index, looking at how this impacts patients' quality of life. So first, let's look at our data. So our primary and secondary endpoints. We can see here that at week 4, over 10% of patients already achieved at least clear or almost clear, which I think is pretty consistent with this medicine. We see a small number of patients achieving that after 1 injection. It's always very rewarding when they come into the office and they for their second injection and they're already clear. That's great. But the medicine does better longer term. So at week 16, we're just shy of 50% of patients having clear, almost clear in terms of scalp. And then at week 52, we can see another increase of about 13 percentage points, with now 62.9% of patients having clear, almost clear. Your blue bars there reflect your placebo arm, and at week 16, those patients were crossed over, and they nicely catch up to our treatment arm, falling at 56% of patients by week 52, achieving clear, almost clear with regard to scalp psoriasis. I think we, now looking at 90%, I think we're all accustomed to seeing 90% and 100% response scores. I think those numbers make us feel better. So we can see here at week 16, almost 2/3 of patients had at least a 90% reduction in their PSSI analysis. and then essentially 2/3 of patients had at 1 year had that 90% achievement. Again, you can see our placebo arm catching up nicely when those patients were crossed over from week 16 to active drug, where they now fall 57% at week 52 in terms of being 90% psoriasis scalp severity index improvement. I always think line graphs, are better than bar graphs. They tell us a story. Bar graphs are so dichotomous. They just give us one endpoint in time. They never really tell you how you got there. So I really like this analysis better because it really shows the response rate and really the speed of response, as well as the number of patients achieving these endpoints. So we're looking at now our psoriasis scalp severity index score in terms of percent change from baseline. So you can see at week 1, we've already had about a 10% improvement from baseline. By week 4, we're around 45%. By week 8, 70%. And by week 16, 80% improvement from baseline in terms of our PSSI scores. So that would be going like from a 20 down to a 4, for example. But you can appreciate that the medicine is not fast in those first initial phases. It's really after that week 4 that the medicine starts to show its strength. And then we can even surmise here that by week 16, that line graph is still going up. And so we would assume that many patients would continue to respond after that. Now we're looking at a 75% improvement as well as a 100% improvement. 75%, obviously, if you're a 90% responder, you got to be a 75% responder. And essentially achieve 10 additional percentage points here for patients being PASI 75 compared to our PASI 90 response. And over a third of patients, believe it or not, were PASI 100. PSSI 100 at week 16. And this is a really important benchmark because, to be completely clear, it's such an incredibly hard metric. If you have one little 1 millimeter scale on the back of your scalp somewhere hidden in your hair, you're by default, a 99.999% responder, but by definition, you'd be a failure under this analysis. So the fact that ILUMYA can achieve complete clearance in over a third of our patients in terms of scalp disease, really an impressive metric. Itch scores, again, we see about half of patients reporting at least a 4-point improvement in itch. So again, that'd be going, say, from a 7 down to a 3 or 8 down to a 4. It doesn't mean they couldn't have gone farther, but the data was reported as a 4-point improvement. And so then we see that being about 3.5-fold better than what we saw with our placebo patients with regard to itch. And then lastly, quality of life scores. If you're not familiar with the DLQI, it's a 30-point score, 10 questions, each scaled 0 to 3. You want to be as low as possible, and in truth, you want to be around a 0 or a 1 across all 30 of those points, because that's been demonstrated to be really no impact on quality of life from your disease. If you fall between a 2 and a 5, it's a small or mild effect from your disease in terms of your quality of life. 6 to 10 is going to be moderate, and then anything above 10 is going to be very large. And obviously, that's where we don't want to be there. So our baseline scores were right in the middle there, around 14. So we know at baseline that these patients are reporting a very large impact of their disease on their quality of life. We can see by week 16 there, after just 2 injections of ILUMYA, we have about a 60% reduction, with now going down to only 4.8. Placebo patients at that point are still showing moderate disease or moderate impact. By week 52, we're right around just under 3 for our treatment arm, as well as our crossover arm for our patients that were switched from placebo to ILUMYA at the week 16 endpoint. So really small impact on quality of life in terms of the psoriasis at 1 year with treatment with ILUMYA. Okay. And the last piece of efficacy really centers around real-world data. And I think, clinical trials, and I know Leon does clinical trials, I do clinical trials. Clinical trials are a really, really important tool, but they don't necessarily always translate perfectly into what our real-world experience has been. And I think if you haven't, tinkered with ILUMYA yet, I think you're going to find that the medicine really hovers around these data points much more so than what we saw at the week 12 endpoint from Resurface 1 and Resurface 2. And I think that's a very important point to make. So here we have three trials to review. This is all at 1 year. Now, some of these trials are a little bit small. So we see 237 patients in the first study there by Narcissi. In the middle study there, 30 patients. And in the last study, 61 patients. But what we're looking at here is really important metrics where, essentially 90% patients were 90% clearer than they were at baseline at 1 year in each of these separate analyses. Some obviously being a little bit higher and some being a little bit lower, but for simplicity, 90% improvement. And patients through these studies also, demonstrated reduced itch. You can see that itch score, this is now looking at the validated itch score, which is a 0 to 100. So that baseline score is around 63. We really rapidly get that score down to a 10 around week 16 after 2 injections. And we can see that it continues to improve out to week 52, hovering around 4, which would be consistent with a very good response in terms of itch. In terms of patient satisfaction, anytime I see a patient with any systemic inflammatory disease, I always ask 2 questions. Are you happy with what we're doing? I think that's always an important starting point. And then, could you be any happier? Is there anything I could do to make you happier than what we're doing right now? That's a very good open-ended question to allow that patient to really spill their guts about it, what's bothering them. Maybe they're happier because they started with an itch of 10 and now they're down to 4, but they say, I would really like to have an itch down to 1. Or maybe they say, I'm a lot clearer, but I'd like to be completely clear. It's a good open-ended question to ask. So what we see here is that patients with ILUMYA at 1 year really demonstrating, very satisfied in terms of both efficacy and tolerability with this medication. Really markers for, does the drug work and is the drug safe to use? Both above 90%. And then lastly, from these 3 studies, we want to make sure that we're not seeing any new safety signals, and that's reflected here. So in the first study, no new safety findings or no relevant side effects were reported. Patients with serological evidence of viral hepatitis had no signs of viral reactivation. That's good. In the second study, no SAEs. The safety profile in patients over 60, there were no new diagnoses of malignancies. Over 12 months of follow-up, 1/3 of patients did have a prior history of malignancy. So now we're getting a little bit more sort of our real-world taste for what our patients in clinical practice look like, and no increase in cardiac disease or infections. And there were no minor SAEs in the third study. There was no treatment discontinuation due to any safety. There was 1 reported death in that study, but it was unrelated to drugs. So now you have good real-world efficacy in terms of response, real-world tolerability and satisfaction with the drug, and then real-world data showing no significant safety signal. All right, the last piece here before we kind of wrap up is metabolic syndrome. And I think that, at least in the United States, metabolic syndrome is a huge part of what we see with our patients with psoriasis. Hopefully you're all familiar with metabolic syndrome. It's a complex of really interrelated risk factors, really focusing on 5 things: central obesity, dysglycemia, hypertension, having elevated triglycerides in your blood, and having a low HDL. And the thought here is that, increased metabolic syndrome is going to have increased systemic complications, namely cardiovascular disease and diabetes, which are both things that, people don't want. So what Sun decided to do was to kind of ask themselves, is ILUMYA going to have a better or effect in patients with or without metabolic syndrome, which is a thought-provoking analysis. So this is pooled data from Resurface 1 and Resurface 2. And what we have bolded here are some key features that really separate these 2 components. So if we look first, for example, in weight at baseline, we can see in patients without metabolic syndrome that our weight was, hovering around 80 kilos, which is almost 25 kilos less than what we saw in our patients with metabolic syndrome. Similarly, our BMI is going to be about 8 points lower. Our cardiovascular disorders were pretty similar, 49% and 40% respectively. And diabetes was also pretty similar, 15% and 15% respectively. The rest of the things there, I think, are unremarkable. So what was maybe surprising, maybe not, was that when we did this analysis, through week 52, we really saw no difference in terms of the response rate for patients with ILUMYA, whether they had metabolic syndrome or not. In fact, one could argue that these lines are exactly identical, only separating around week 8. And even at week 8, they're really maybe 1 to 2 points off from where the patients without metabolic syndrome lie. And then finally at week 52, there's maybe a 2 or 3% difference, 2 or 3 point difference there. As we follow these patients out through over time through week 52, week 100, week 148, we again see no real difference in terms of the response rate, whether patients had or did not have metabolic syndrome. And then in terms of safety, we can see here, again, asking ourselves to look at the far left first, we see hypersensitivity, infections, MACE events, cardiac disorders, and endocrine disorders. We can see that these numbers are overall very low. Again, we see no hypersensitivities, which is great. Our serious infections were 1% and 0.7% respectively in the 2 groups. Confirmed MACE was 0.4 and 1, so we actually had a 2.5-fold higher rate of MACE events, if you will, by percentages. You have to remember that the numbers are much different because the patients without metabolic syndrome represent a larger portion than those patients with. And then we can see cardiac disorders again being higher in our metabolic syndrome population, as well as endocrine disorders. A few other safety things: GI disorders, general disorders of and administration of psych conditions, psychiatric disorders, respiratory and vascular disorders. Again, really nothing noteworthy to report here. Pretty similar across the two groups. Okay, and that brings us to the last piece, which sometimes may be the most important, right? So we've got a drug that we've demonstrated has good efficacy. We've got a drug that has good safety. Can you actually get it? And that still sometimes can be a challenge. So remember that ILUMYA is administered at week 0, week 4, and then every 12 weeks thereafter, 100 milligrams, only available as a pre-filled syringe, and it has to be administered by a healthcare professional. It's a single injection pre-filled syringe. It's actually a very low volume, which is good. It's stable at room temperature for 30 days. So even if you take this medicine out and your patient doesn't show up to the office, for example, you can always call that patient and say, you know what, hey, you missed your appointment on Monday. Any chance you can get in this week? As long as you get that medicine into that individual within 30 days, you're good to go. Once it's out of the refrigerator, you don't want to put it back in. I joke sometimes that just like a good beer that warms up to room temperature, you can't put it back into the fridge after that. You got skunky beer, and nobody wants skunky ILUMYA. And this is where Sun can really play an important role. So all of our biologic companies really are huge assets to us as clinicians. We know that these medicines play an important role in our patients' disease and quality of life. And it's really important that companies have tools in place to help us. So obviously, with this product, you have your hub services. That's where your benefits verification is going to be done. That's where your prior authorization management support can come from. That's all same as with denials and appeals. And they also offer some patient support services. For those patients that may be impoverished or fall below the federal poverty level, Sun assigns a 400% federal poverty level benchmark. So if you're below that, you can get patient assistance with this product. They have a copay card, which should, if you have commercial insurance, allow you to get this medicine for as low as $0. The maximum annual benefit in the United States with this is $16,000. And then, of course, they have early access programs. My personal approach to any patient with psoriasis is I always inject at the time of diagnosis. I think that's a really important point. I also want to make sure that if for some reason there's a hiccup in terms of getting the medicine approved, my patient's then not going to have the ability to enroll or to get that medicine at week 4 and going forward. So Sun offers that as well. And I think that's an important point to make. Now, in terms of one nice benefit here, because this medicine does require administration by a healthcare provider, it offers 2 types of coverage. You have your commercial insurance, which is basically the same commercial insurance approach that we have with any biologic. So if your patient has commercial insurance, you want to get them ILUMYA, you would do it just like any other medication. The medicine is then delivered to your office, and then you administer it to that patient under a commercial insurance plan. But for patients with Medicare, or as I like to joke, Medi don't care, because Medicare makes things really hard for us, they also have an option to get ILUMYA, and that's through the buy and bill pathway. And you only have this option because it is a healthcare provider required administrative drug. And we all know that psoriasis doesn't magically go away as soon as you get Medicare. So for those patients who have Medicare, you can actually get them ILUMYA through buy and bill. And I actually have experience with both of these. I think they both offer some niche benefits. With the commercial insurance one, it's just as easy as any other biologic, in my opinion. Again, the medicine just comes to your office and you administer when the patient comes in. For the buy and bill part, yes, there is an upfront cost to whether it's to your column as a physician or to your company, whatever it may be. But then when you administer that medicine and you submit it for the reimbursement, usually within about 45 days, that reimbursement kicks back into your column. And of course, you do make a small little profit there. So I would never elect buy and bill as an opportunity just to increase revenue. It's really more of an opportunity to give a patient who has Medicare insurance a quality drug that helps treat their psoriasis. So if I've done a good job this evening, and again, I want to thank everybody for your attendance. Hopefully I've demonstrated this medicine does deliver good efficacy. I think that week 28 endpoint the week 12 endpoint did hurt them initially, but we know that 23 is enriched over time. We now have really good data showing PASI responses below 1 long-term with that nice stability. We saw real-world data that showed good tolerability and effectiveness of this drug. We also showed very low safety signals. And of course, you know, at the end of the day, it's 4 injections a year after that loading dose. And then we did wrap up with Sun's commitment to our patients and us as providers to help patients get the medicine that they require. Here's a couple references in terms of any medical information that you may seek. And with that, I will open up the forum for any questions, comments, thoughts, criticisms, feedback, opinions, and whatnot. And thank you.
Thank you, Dr. Payette. That was really eye-opening, and I learned a lot. I haven't seen one of those presentations for a while, so that was really refreshing. And Ashley, can we move on? And I'd like to thank, if you have any questions, anybody, please, you know where to put it on the pane so that we can see those. Next slide, Ashley. I'd like to thank Sun Pharma, our sponsor for tonight. Actually, I do see a couple of questions here. One is really interesting question. It's a good one. What was the rationale? Why is this biologic have to be given in the office by a healthcare provider?
Yeah, no, that's a great question. And actually, that's one that comes up quite regularly, especially for patients with psoriasis, because most psoriasis patients, especially if they've been exposed to some other therapy, you know, they have the option for, you know, having that medicine administered at home versus having it, you know, done by their provider. The answer comes from the fact that when this medicine was originally studied, and it's important to note that this was the first IL-23, selective IL-23 that was studied, it was studied and using a healthcare administered product. And when they submitted the approval to the FDA, because that was how it was done in the clinical trial, that's how it got approved. And that's really the simplest answer as to why the medicine has to be administered in the office.
So next question.
I actually think it's a great option because it gives you 4 times a year to check in with your patients, which is nice.
Yeah. The next question naturally that follows this one is, what are the disadvantages or advantages for that matter for the in-office administration?
Yeah, there's kind of a multifaceted answer there. The main advantage, in my opinion, is that you get to see your patient 4 times a year, and I think that's nice. You know, really, for a lot of the other medicines, you know, maybe see them every 6 months, maybe see them once a year. So it's nice to check in with your patients and see how they're doing. The disadvantage, obviously, is going to be if it has to be administered by a physician or other provider, somehow the patient has to get there. So in areas like Connecticut, where I live, you know, maybe the longest distance you're going to drive is, you know, 20 miles. But in the Midwest, you know, that could be a big deal. You may have to drive 2 or 3 hours to see your physician. Now, it's important to note that you don't necessarily have to administer the medicine yourself. So this medicine can also be administered at any infusion center. And I think that's an important point. So if you don't necessarily want to do it in your office, all you have to do is connect that patient with an infusion center or other facility that offers injections, and your patient can do that, which often will create a more geographical acceptable option.
Perfect. Thank you so much, Michael. That was really very illuminating. And I think we're almost close to the top of the hour. I'd like to wish everyone good night, but also I'd like to let everybody know that now we are done with our Sun Pharma program. Thank our sponsor, Sun Pharma, and then our next program will be on September 12th, and it's going to be sponsored by Galderma. It's the IL-31 neuroimmune pathway, the key to prurigo nodularis. It's going to be very exciting about a new drug just got approved, and our speaker will be Dr. Daniel Butler from Arizona. Again, thank you, Michael, and good night, everyone.
Thank you, Leon. I appreciate it. It's always good to see you, pal. Be good.
Bye.